Good morning. I'd like to thank the program committee for the opportunity to present this study from our departments of surgical oncology and medical endocrinology. We have no disclosures relevant to this presentation. Several factors make the management of patients with adrenocortical carcinoma very challenging. First, this is a rare tumor with an annual incidence of only 1 to 2 per million. Secondly, the overall survival is poor, with only 30 to 45% of patients surviving 5 years. In addition, the resections are very technically challenging due to the frequent friable nature and common extension through the capsule of the adrenal gland and into surrounding structures. Additionally, groups, including ours, have continued to search for an effective adjuvant strategy for these patients. It is important to note, however, that long-term survival is not possible without complete resection. In addition, the challenge of preoperatively establishing a diagnosis has historically made the management more complicated. However, recent advances in cross-sectional imaging have greatly improved our ability to reach this diagnosis preoperatively. Multiple studies have shown that the characteristics listed have been associated with increased diagnosis of malignancy. And at this point, if you can preoperatively identify a heterogeneous mass with irregular margins and the presence of either venous extension, calcification, or central hemorrhage, there should be little hesitation in determining that this is a malignant lesion. If these factors are not present, then evaluation of the attenuation in Hounsfield units or the rate of IV contrast retention may also help establish the diagnosis. Fortunately, there is currently little need to make the decision to resect an adrenal mass based solely on size. As surgical techniques have also evolved, laparoscopic adrenalectomy has become the preferred approach for most adrenal lesions. Similar to laparoscopic colectomy, studies comparing laparoscopic and open adrenalectomy for patients without adrenocortical carcinoma have shown that short-term postoperative outcomes are improved, including things such as transfusion rates and ICU length of stay. These data have been used to suggest that a laparoscopic approach may also be appropriate for adrenocortical carcinoma. However, results of oncologic outcomes from previous studies have been mixed. And as previously stated, the importance of surgical resection with long-term outcomes for these patients means that surgical technique is of utmost importance. For these reasons, we designed this study to compare oncologic outcomes for patients with adrenocortical carcinoma undergoing laparoscopic versus open resection. The outcomes of interest were overall survival and recurrence-free survival. We particularly wanted to focus on patterns of recurrence, so we also looked at peritoneal recurrence-free survival. To assess these outcomes, we performed a retrospective review of all patients with adrenocortical carcinoma referred to our institution between April of 1993 and May 1st of 2012. We divided the patients into 3 groups: those who underwent a laparoscopic resection, which were all done at an outside institution, those who underwent an open resection at an outside institution, and those initially resected at our institution, all by an open approach. We then performed a complete radiologic review to classify the recurrence patterns. The median follow-up for all patients in this study was 34.4 months. We identified 46 patients who had undergone a laparoscopic resection at an outside institution, 210 patients who had undergone an open resection at an outside institution, and 46 patients who were initially treated at our institution. This table shows clinical factors in the 3 groups. As you can see, there was no significant difference in the gender distribution between groups. There was, however, a significant difference in the median age, with the patients being initially treated at our institution being significantly older than those treated initially at an outside institution. And perhaps most significantly, the patients in the laparoscopic group had a lower median tumor size relative to either of the 2 open groups. This table demonstrates certain pathologic characteristics of the 2 groups. While the overall T-stage distribution was not significantly different between the 3 groups, it is notable that the laparoscopic group had 20% of patients with a T1 pathologic diagnosis, whereas only 1% of the patients at the open outside hospital group and 4% of the patients treated at our group had T1 lesions. and none of the patients in the laparoscopic group had T4 lesions, while these patients comprised 16% of patients in the open and outside hospital group and 22% of our patients. In addition, patients treated by a laparoscopic approach had a higher percentage of positive margins than those in either of the two open groups. This is a Kaplan-Meier curve for peritoneal recurrence-free survival by the three different groups. On the y-axis, we have the proportion of patients alive and without a peritoneal recurrence. Along the x-axis, we have the length of survival. The green curve represents the patients treated by an open approach at our institution. The blue curve represents those treated by an open approach at an outside institution, and the red line represents those patients treated by a laparoscopic approach. As you can see, the peritoneal recurrence-free survival was significantly worse for patients in the laparoscopic group relative to the two open groups. This graph shows a Cox regression analysis modeling recurrence-free survival with adjustment for T-stage of the tumor. In this graph, the green curve represents the two combined open groups, whereas the red curve represents the patients in the laparoscopic group. This also shows that recurrence-free survival was significantly higher for the patients in the open group. Next, we wanted to evaluate the significance of a peritoneal recurrence. So we looked at patients with different types of recurrences and determined which of those patients were able to subsequently undergo resection for their recurrent disease. As the graph illustrates, only 15% of patients who had a peritoneal recurrence were subsequently able to have surgical treatment, whereas 35% of patients with all types of recurrence were able to undergo subsequent resection. Finally, this curve shows a Cox regression analysis modeling overall survival with adjustment for T-stage. Again, the green curve represents the combined open groups, and the red curve represents the laparoscopic group. Although you can see that early survival for the laparoscopic group was slightly improved, once we get beyond about a year, the patients in the open group have a higher adjusted overall survival. This study has several limitations. It is a retrospective study, and therefore all the biases inherent to retrospective studies are applicable. In addition, these patients were all referred to a tertiary hospital. However, we did look at the percentage of patients treated at an outside hospital who were referred prior to recurrence, and this was similar in both the laparoscopic and open groups. In addition, some baseline characteristics in the three groups were not balanced. However, the laparoscopic tumors had smaller overall size and a trend towards a lower T-stage, which, if anything, should balance the results in favor of the laparoscopic group. Although the laparoscopic group did have a higher rate of margin positivity, we feel that this is more a limitation of the technique of laparoscopic approach rather than something that should be controlled for in this study. So in conclusion, despite laparoscopic resection being undertaken in smaller tumors, it was associated with higher rates of peritoneal recurrence than an open approach. In addition, patients who developed peritoneal recurrence had lower rates of surgical salvage than patients with all other types of recurrence. This is significant because previous studies have shown that for patients with recurrent adrenocortical carcinoma, the ability to undergo subsequent surgical resection is associated with significantly improved long-term survival. With modern imaging, the preoperative diagnosis of adrenal malignancy should rarely be in doubt. For patients with adrenocortical carcinoma, the surgical approach may directly influence long-term oncologic outcomes and therefore should be considered when determining the surgical approach. And based on these data, we feel that open adrenalectomy should remain the standard of care for patients with this challenging disease. Thank you.
Thank you. Okay, we have a couple of questions right away. Please go ahead.
Michael Brunt, St. Louis, congratulate you on this nice study and for addressing one of the important controversial topics in adrenal surgery. My question relates to the patients with the T1 and T2 tumors. You showed that there was a little bit of a worse survival curve adjusted by T-stage. But can you tell us a little bit more about those patients with T1 and T2 tumors who had the laparoscopic approach? Your median overall size in the laparoscopic group was 8 centimeters. So there were a lot of patients that had larger tumors than 8 centimeters that underwent an attempted laparoscopic resection. In the patients with the smaller tumors, are there tip-offs on the preoperative studies that suggested this was an adrenal cancer, or were these indeterminate lesions? Because that's one of the challenges in dealing with these 5 to 6 to 7 centimeter tumors. Not all of them are adrenocortical cancers. Some of them are benign lesions. So it involves selection not just based on size, but also by the imaging characteristics. So do you have any more information about the details of those patients, and how many of these were done in high volume centers before they were referred to you? Do you have any information about the relative experience of the individuals doing those laparoscopic adrenalectomies? Thank you.
Those are both very relevant questions. Unfortunately, since these patients were treated at outside institutions, the data that we have on the preoperative imaging characteristics is variable, and we don't have that data for all of the patients. Similarly, the data on the experience of the surgeons performing the resection is also lacking for almost all of these patients, so I can't really comment too much on that, but those are certainly important factors to keep in mind. I think with the current information about imaging characteristics today, there should be, in most cases, you should be able to establish the diagnosis prior to resection. However, certainly at the early part of the study, that may not have been the case for many of these lesions.
Yes, please, next question.
Pascal Fuchshuber from Walnut Creek, California. I understand that you use these very good criteria preoperatively to rule out carcinoma versus not, but I'm sure that in your center you have done laparoscopic resections and encountered adrenocortical carcinoma, even though you may have not thought it was there in the beginning. If so, what do you do when you are in the laparoscopic mode and you realize this could be something else? Could you describe to us?
We actually don't have any patients that were treated at our institution that were started laparoscopically and then discovered to have an adrenocortical carcinoma. I think the patients at our institution tend to undergo a pretty thorough biochemical and radiologic workup, prior to going to the operating room. That's not to say that it won't happen at some point, but I think the approach from our group, if that were to happen, would be to immediately convert to an open resection, because we feel strongly that for these tumors, which frequently extend beyond the capsule microscopically and you frequently involve other organs, that being able to perform a wide resection is critical to their management.
All right. One more question, please.
Keith Applegren, Pittsburgh. Two quick questions. One is, could you evaluate the completeness of the resection from an oncologic standpoint if it's done laparoscopically? In other words, did they do nephrectomies with these? But the more important question is, if you have a patient referred from an outside institution that has a positive margin, do you then proceed to an open procedure, or do you wait to see if they have a recurrence?
So with regard to the first question, some of the laparoscopic procedures did include nephrectomies. Hard to know retrospectively how many of those might have included a nephrectomy that were not done laparoscopically had they been started with an open approach, but some of them did include nephrectomies. With regard to the second question, our general approach to patients referred to us with a positive margin is to offer them adjuvant therapy, typically with mitotane, sometimes with chemotherapy as well, and then to follow them closely. In the event that these patients do experience a recurrence, then if they don't have any distant recurrence and are otherwise appropriate candidates for resection, we're pretty aggressive in taking them back to the operating room to resect the recurrent disease.
All right. Thank you very much.
Thank you.